Good afternoon, everybody. This is your lecture on diabetes and thyroid issues. First off, I'm going to be talking about Chapter 66 and diabetes. Your pancreas creates two hormones that help maintain your blood glucose levels. The first one is insulin, which decreases your blood glucose levels. The other one is glucagon, which increases your blood glucose levels. If you have an issue with either of those hormones, then you have diabetes. There are two different types of diabetes. Type 1 diabetes is an absolute lack of insulin production by the pancreas. These diabetics are dependent on insulin, and it is considered the juvenile diabetes because most people are diagnosed as children with type 1. Type 2 diabetes is the more common form. It's considered adult diabetes because adults get type 2 more often. This diabetes is insulin resistance. That's when their body cells do not respond to insulin. These types of patients are usually overweight, and they're on some sort of oral anti-diabetic and can possibly take insulin also. Signs and symptoms of diabetes. There is a triad of these that indicates diabetes. The first one is polyuria, and that is excessive urination. The second one is polydipsia, or excessive thirst. The last one is polyphagia, and that is excessive appetite. If you have a patient come in and they are exhibiting all three of these symptoms, then you are definitely going to test that patient for diabetes, and you're going to do that with a hemoglobin A1C. That is going to give you their blood sugar level over the past 3 months. The main key to preventing diabetes or even reversing diabetes is exercise, diet, and weight management. As you can see on this slide, diabetes affects almost every system in your body. We're going to look at diabetic ketoacidosis next. That is an acute condition that needs to be treated emergently, and that's going to be mainly in patients that have type 1 diabetes. Diabetic ketoacidosis is hyperglycemia, so blood sugar levels are high. They're going to exhibit the triad of symptoms for diabetes, and their breath is also going to be fruity because the lungs are trying to push the acidosis out of the body's symptoms. Again, this is an emergently treated situation. Page 1115, prototype drug, glucagon. This is an anti-hypoglycemic drug. This is used in treatment, again, for emergency situations with low blood sugar. Most of the time it's given IV. It can be given IM or sub-Q, but most of the time you're giving it to a patient who already has an IV, and it's just given IV. It can raise glucose levels in 10 to 20 minutes, so you need to be monitoring that patient's blood levels. Glucagon is dependent on the presence of adequate liver glycogen stores in order to function. When you're caring for a patient that has diabetes, you're always going to get a baseline serum blood glucose level. Then, after you give the glucagon, you're going to get another blood sugar level. And then after you give it, you're going to give a blood sugar level. You need to be monitoring this patient very closely. It's important to know that children under the age of 6 require only 1/2 of the adult dose. Page 1117, insulin therapy. Type 1 diabetics require insulin to survive. Type 2 diabetics, they are just unable to manage their blood glucose levels. The most important thing to remember about insulin is that the right amount of insulin has to be available when glucose is present in the blood. That's the key to it working. Page 1118, table 66.2. You need to be aware of the rapid acting insulins, short acting insulins, intermediate acting insulin, and long acting insulins. You need to know the difference between them. And remember, you only need to know the chemical name, not the brand name. Page 1119, prototype drug, human regular insulin. What type of drug is it? Short acting, hypoglycemic. This is going to help your patient maintain their blood sugar levels within normal limits. Contraindications would be people that are allergic to beef or pork, or have a religious situation where they cannot ingest either of those, because that's what they used to be made of. That's rare now. Mainly they are just chemicals that are produced. But you also need to be careful if you're giving human regular insulin R to people with renal impairment or failure. You also have to be careful if you are using human regular insulin with other drugs that can produce hypoglycemic effects. Those would be sulfonylureas, meglitinides, beta blockers, salicylates, anabolic steroids, MAOIs, and alcohol, because this is going to make the hypoglycemic effect of insulin worse. Insulin aspart. It's a rapid onset drug and is more rapid than human insulin R. It works very quickly, so you should only give the injection 5 to 10 minutes before meals. It has a very short duration of action, only 3 to 5 hours. So this medication, this insulin aspart, is usually given with a medium to long acting medication also. Insulin Det Mir. This is long acting, slow onset. It can be given once or twice a day, depending on the dose, and it can last up to 12 hours. Det Mir is used to provide basal glycemic control. That means it is to be given to keep you on a level blood sugar number. Det Mir cannot be mixed with any type of other insulin and is only given by sub-Q. Insulin Glargine. This is a newer drug. It has long duration activity and is constant, keeps a level. It's once daily dosing. It should be given at the same time every day. It cannot be mixed with any other insulins and is only given sub-Q. Insulin Glucagon. I don't think there's going to be any questions on the test regarding this one, so don't have to worry about that one. Insulin List Pro. This is a rapid acting regular insulin. The effects begin to show within 15 to 30 minutes of injection. It is faster than regular insulin but has a shorter duration. Insulin List Pro, because it is fast acting, needs to be given either immediately before your patient eats or while they are eating. It is used to control the rise of blood sugar levels. It is a clear insulin, and it is often used with insulin pumps. Isophane insulin is an intermediate acting insulin, the only one of its kind. It has a slower onset, and the duration can last 18 to 24 hours. It's also used to provide a basal level of insulin coverage. And insulin isophane can be used with other drugs. Isophane is a cloudy suspension and requires mixing before drawing up the dose. You can give isophane with aspart, List Pro, or regular insulin, only those. Remember, when you're drawing up two different types of insulin into the same syringe, it is always clear before cloudy. Drugs for type 2 diabetes. There's a table 66.4 on page 1121. You need to be aware of those. You don't really need to know the incretin enhancers, but the rest of them would be good to know. Page 1122, the biguanides. Metformin, it's an important drug for you to be aware of. Glimepiride and glipizide are important drugs for you to be aware of. Page 1123, nursing practice application. It's very important when you assess your patient, you get a baseline blood sugar level, okay? You also need to know, you need to talk to those patients and see, what does your blood sugar run? If, 200 may be high for somebody else, but that may be what that patient runs on an everyday basis. You need to ask them how they treat themselves at home. Are they treating themselves correctly? You need to continue to monitor their blood sugar levels, especially if they're in a crisis. You need to make sure that you're administering the insulin correctly and as ordered. You need to make sure that that patient understands the dietary needs and the dietary restrictions and that they are compliant with that. You are going to hold the insulin dose if the blood sugar is less than 70. You're going to monitor laboratory values. You're going to monitor your patient for hypo and hyperglycemia. You're going to encourage that patient to exercise. You're also going to encourage that patient to rotate. The patient should be rotating insulin injection sites daily to weekly, because the injections can create lipodystrophy, which is destroying the cells in that injection site. They need to be aware that insulin can be absorbed differently in different areas of the body. Insulin needs to be stored properly. Some of it requires refrigeration. The patient needs to carry a quick-acting carbohydrate source. They need to know how to check their blood sugars correctly. They need to know how to inject themselves. And if they cannot, then the caregiver needs to be taught this. Sulfonylureas, page 1125. There are two different generations of sulfonylurea drugs. The second generation exhibits fewer drug-to-drug interactions. What's the patient you're not going to give a sulfonylurea? That's right, the one that's allergic to sulfa. Prototype drug, glyburide. The primary adverse effect of glyburide is hypoglycemia. So if your patient's already hypoglycemic, you're not going to give them this. Contraindications would be your patients who have sensitivity to sulfa drugs or thiazide diuretics. A second generation sulfonylurea, glimepiride. Another one, glipizide. Glipizide should not be chewed or crushed. Page 1126, prototype drug, Metformin. This comes in different forms. It's a tablet, and this is usually taken once in the morning. It reduces blood glucose levels by multiple mechanisms. Adverse effects are usually GI related, including nausea, vomiting, diarrhea, abdominal discomfort, and moderate weight loss. Metformin is not used in patients with impaired renal function because it can make the drug rise to toxic levels. It's also contraindicated for patients who are receiving contrast. They should stop it 2 days before and 2 days after. All right, now we're moving on to Chapter 67, Thyroid Disorders. Thyroid hormones contain iodine and stimulate the basal metabolic rate of nearly all tissues. There are two distinct hormones, T3 and T4. T3 stands for triiodothyronine, and T4 stands for thyroxine. T3 and T4 are metabolized by the liver and mostly excreted by the kidneys. Iodine is conserved in this process and sent back to the thyroid gland in order to meet your daily needs. That's why we are not supposed to have very much salt in our diet. When your thyroid hormones become low levels, the hypothalamus secretes thyrotropin releasing hormone, or TRH. When that is secreted, it can stimulate the anterior pituitary to secrete thyroid stimulating hormone, TSH. Then it stimulates the thyroid to produce T3 and T4. Thyroid disorders can be congenital, or you can develop them later in life. When your thyroid gland is increased in size, it's referred to as a goiter. They usually involve the whole gland, but sometimes can just involve one node. This can become a life-threatening situation because it can put pressure on the trachea and esophagus, causing difficulty swallowing and possible issues with your breathing. It can also compress the superior vena cava, which will cause distension in your neck veins and facial edema. Page 1139, Table 67.1. It talks about the thyroid test and what it shows, whether it's hypo or hyperthyroid. Hypothyroidism in adults results in the slowing of your metabolic processes and myxedema. This is a mucus type of edema that is caused by an accumulation of hydrophilic substances in connective tissues. There are 3 different types of hypothyroidism: primary, secondary, and tertiary. Primary is the most common, and it's caused by a dysfunction of the thyroid gland. Secondary hypothyroidism is due to a pathology of the pituitary gland. Tertiary hypothyroidism is a result of the disorder of the hypothalamus. Some of the causes can include a thyroidectomy or ablation of the thyroid gland with radiation. Large amounts of iodine or other substances that contain iodine can block thyroid hormone production. The most common cause of hypothyroidism is an autoimmune disorder known as Hashimoto's. This usually affects women and can be caused during the first trimester of pregnancy. It affects all of your major organ systems. Table 67.2 shows signs and symptoms of thyroid emergencies, myxedema coma, and thyroid storm. It'd be good to know these. Page 1141, prototype drug, levothyroxine. This is usually given by PO route, and it can take 1 to 3 weeks for it to become at a therapeutic level. Adverse effects include tremors, headache, nervousness, insomnia, palpitations, tachycardia, angina, and cardiac arrest. Table 67.3 at the top of page 1141, it talks about drugs for hypothyroidism and their adverse effects. Levothyroxine needs to be used with caution in patients with cardiac disease, angina pectoris, cardiac dysrhythmias, hypertension, impaired kidney function, and in older adults. Also, symptoms of diabetes can worsen administration of thyroid hormone. So your medication, your levothyroxine, may need adjusted due to that. There are several drugs that accelerate the metabolism of levothyroxine. That's including phenytoin, carbamazepine, rifampin, phenobarbital, and sertraline. It's important to note that levothyroxine increases the effect of warfarin. So what's that mean? Increased risk of bleeding. Digoxin decreases the effectiveness of levothyroxine. So if you have a patient who's taking digoxin, their levothyroxine levels are going to be higher. Make sure you're looking at page 1143 in the nursing practice application of patients receiving thyroid hormone replacements. Now, hyperthyroidism. Most common cause is Graves' disease, and that's where you're going to see the symptoms will be goiters and exophthalmos, which means your eyes are bulging out. Page 1145, table 67.4, anti-thyroid drugs. You need to know all of them. There's only 4, never fear. Page 1145, prototype drug, PTU. This medication decreases thyroid hormone levels and is used to establish normal thyroid states. Black box warning on this medication. It can cause severe liver injury and acute hepatic failure. It also increases the actions of anticoagulants, which increases your risk of bleeding. Any drugs that contain iodine can antagonize the effectiveness of this drug. If you take too much of this drug, you can induce hypothyroidism. 1146, radioactive iodine. That's 131I. Iodine is taken up by the thyroid gland, where the radioactivity destroys thyroid tissue. The goal of this therapy is to destroy part of the gland, thereby decreasing the amount of thyroid hormone produced and secreted. Therapeutic effects develop very slowly over 2 to 3 months, and tissue damage is limited to only the thyroid gland. No other tissue surrounding it is affected. Make sure you're looking at your nurse practice application on 1147. You know your baseline assessment, your reassessments, your educations, and therapeutic effects and minimizing adverse effects. I hope this helps everyone. I've gone through it pretty quickly, but I've hit all the key points. So I hope you guys have an amazing Thanksgiving break, and I will see you the Monday after. Bye-bye.